Good morning. We're going to go ahead and get started. Thank you all for attending the VHA Innovation Experience demos. My name is April Jones. I'm an Innovation Specialist in the Tuscaloosa VA, and I'll be your MC this morning. We hope that you're enjoying your time and enjoying all the other events that are going on. Do remember to tweet or post about your favorite demo using the VHA iEx app if you've not downloaded that already. Just some logistical reminders that all of our presenters, you will have exactly 5 minutes to present. And for presenters, the timekeeper, which is Shelly, if you want to raise your hand, she will be helping you to keep your time. And she's going to give you a 1 minute posting when you have 1 minute remaining in your presentation. And then we'll indicate again when you have 30 seconds remaining in your presentation. Please stick to this time limit because running over your allotted time is going to affect the other presenters. So for some introductions, today we're fortunate to be joined by a graphic illustrator who will illustrate our practices throughout the session. You remember this from last year. Very nice. Each demo session will be scored and based on several criteria, including the innovativeness of the solution, its impact, and the overall delivery of the presentation. These scores will be used to determine the recipients of the VHA iEx Demo Awards The winners will be announced at the award ceremony this evening at 4:30 p.m. So let's move on to our presentations, which is why we're all here. Our first presenter in the Health Enabling Technology track is going to be Patrick Aubin from the VA Puget Sound Healthcare System, who will be presenting on 3D printing custom foot orthotics for prevention of amputation.
Oh, there you go, thank you. Again, that's me, thank you for the introduction. America is facing an epidemic of diabetes. There are more than 30 million Americans that have diabetes, and this is resulting in 225 daily amputations. If left uncontrolled, diabetes can lead to peripheral neuropathy. Then in conjunction with mechanical stress, this can result in diabetic foot ulcer. If this ulcer becomes infected, oftentimes amputation is performed. Currently, the VA cares for more than 500,000 veterans who are at risk for these types of ulcers. The good news is that custom footwear can reduce the risk of amputation by close to 50%. Controlled diabetes with custom footwear and orthotic leads to happy, healthy feet, which is what we want. The problem is these orthotics are difficult and time-consuming to manufacture, and often there's a post-production step that involves grinding, sanding, and digging out various aspects of the insole. During this time, the patient is at risk for developing an ulcer while they're waiting for the prescription to be filled. Oftentimes, these are also sent out to be manufactured, and that creates a long lead time. Therefore, the purpose of our project was to reduce the time needed to manufacture a custom diabetic orthotic, and therefore reduce the risk of developing ulcer while waiting for the prescription. Our solution was to rapidly 3D print custom foot orthotic. We envisioned a pipeline that started with a clinical evaluation, followed by a 3D scan of the foot. Then we would design the insole in software algorithmically, 3D print it, and deliver it to the patient. First step is to capture the foot. We evaluated many different scanning technologies, and right now we're using this foam crush box, which is what clinicians are currently using and are familiar with. Then we 3D scan to get the surface geometry of the foot. We then design the orthotic to have the right length and width and thickness to also fit into the patient's shoe, and not only be conformal to the patient's bottom of their foot. We have developed a variety of different lattices. We can tune the bulk material stiffness of the orthotic by having a dense or thin lattice. And I'm going to go ahead and pass these around so you can feel for it. By tuning the lattice and adjusting it to the plantar pressure of the foot, if the patient has a hot spot for a particular region, we can make that lattice specifically soft or stiff in exact regions according to what the patient needs. We then get the final 3D orthotic design. So this has a surface geometry that is exactly matched to the patient's foot, as well as a lattice that's unique to that patient and to their exact needs to maximize the benefit of the orthotic. Next step is printing the orthotic. We evaluated a variety of different materials in terms of their strength and resilience, durability, and overall suitability to be 3D printed. Two of the materials I'm passing around now, you can get a feel for them. We also evaluated a number of different 3D printing technology platforms in terms of cost, throughput, size, to see which one of these is going to be best suited for what we need. We did durability testing. There is a number of people, if you want to raise your hand, who have been walking in these orthotics. Raise your hand, guys. We have over 4 million steps collected so far. We're doing durability testing. We want to exceed the durability of the current standard of care. So now we have a 3D printed orthotic. I have a couple of prototypes here. I'm going to pass these around that we can manufacture. We're getting more rapid every day. They have really nice properties that are suited for the individual. So I'm going to pass out three different examples. You can feel different materials for the different lattices. Moving forward, we're going to be applying for a grant to look at the efficacy of these devices when they're actually used by patients. And also we want to further leverage the digital manufacturing process to increase the customization and really improve the efficacy of these devices. Thank you. And my teammates, of course, I want to thank them.
Thank you, Patrick. That was great. Our next presenter is Pete Spanos from the VA Loma Linda Healthcare System, who's going to talk about the appointment tool for mental health transitions of care.
Good morning. Thank you for the introduction, April. I'm excited to be here to tell you a little bit about our appointment tool for transitions in mental health care. 1,208. That's the total number of currently active clinic locations across the mental health service of VA Loma Linda. Imagine our frontline scheduling staff needing to scan 1,200 clinics to find the first available appointment of a specific type, like the intake appointment, at a specific location, like the ambulatory care center, with a specific provider, like a therapist, and of a specific type, or a specific provider type, like a therapist, in real time with the veteran in front of them or on the phone. With multiple programs, provider types, and treatment modalities, mental health scheduling can be challenging, as we can see with a sampling of 1/10 of just our outpatient VHIP clinics. The complexity of the problem led to many schedulers unable to complete orders, the providers themselves spending 10 to 20 minutes searching for an available appointment, and veterans leaving the facility without an appointment in hand. It was an overall experience of resource waste and frustration. The project team asked, how might we improve the experience to make it easy, less time consuming, and reduce errors? We began iterative development of an innovative tool that pulls near real-time grid availability from national servers into an Excel file with quick access buttons programmed with logic to find first available appointments. At the same time, return to clinic order locations were co-designed for transitions in mental health care that correspond to these buttons in naming convention. So now, providers knowing that a veteran needs a follow-up appointment for a VHIP intake at the ambulatory care center can write that transitions RTC, and when the veteran goes to schedule that at checkout, either in person or later over the phone, the clerk uses the tool to click the corresponding button. Easy, quick, minimal errors. During the project period, 4,900 RTCs were processed using the tool. In a return on investment analysis, direct use of the tool to process these orders resulted in $73,000 in savings in labor cost avoidance. Further estimating indirect use of the tool by providers doing appointment searches outside of the transitions RTCs yielded an additional $218,000 in potential savings. Ultimately, aligning clinical intent with scheduling outcome benefits the experience of veterans and staff. So providers can write a transitions RTC knowing that in one click, schedulers will be able to fulfill it, and veterans will have an appointment at the first point of scheduling contact. We've also just added a feature to the tool that you can see at the top there that gives a dynamic snapshot of 20-day availability across the different types of mental health appointments to have readily available community care decision support. So providers and veterans can decide on an appointment or community referral and veterans can get the mental health care they needed without delay. Thank you.
Thank you, Pete. Our next presenter is Danielle Krakora from the VA Northeast Ohio Healthcare System, who's going to talk about Challenge America Makers for Veterans, or CAMVETS.
Thank you so much. So I'm really excited to share this incredible program with you, but it's just as much a program as it is a partnership. So it's a partnership between the Cleveland VA, obviously, the VA Innovation Ecosystem, Challenge America, which is a Vince Gill and Amy Grant nonprofit out of Colorado, and the Cleveland Clinic, which is a global leader in healthcare innovation. So it's really unique and cool in that respect that we really share ownership of this program, and I get to be here to share it with you. So briefly, to tell you a little overview, then I'm going to go in and give you an example of one of our teams. We take a disabled veteran, usually with a physical challenge that's preventing them from doing something they once loved. Then we assemble a team of experts. It's a great cross-section between VA providers, private sector business and industry, and academia around that veteran's challenge. They meet about a month and a half ahead of a program. They meet their veteran, they strategize, refine their approach. They may use 3D printing to print some prototypes, and they really figure out what they're going to do to solve that veteran's challenge. And this culminates in a 72-hour event, which takes place in a really creative makerspace where these projects are assembled. And at the end of it, through a partnership with VA Tech Transfer, we're able to assign a provisional patent for all of those projects. And then we seek for creative ways to future fund those projects into development. So a solution for one veteran is really a solution for many. And what's unique is the veteran is at the center of it. They're providing constant feedback because they are the heart of the team. So I'm going to tell you this, explain it a little bit more with a story. So I want you to meet Chris. Chris is an OIF veteran, so he deployed, I think, 3 or 4 times to Afghanistan. He was significantly injured in combat. And this kind of leads to debilitating pain and lack of mobility. So he's really young. He was recently married, and his wife was, at the time, expecting their first child. So in Chris's mind, in Chris's words, he said, "The challenge is important to me for multiple reasons. Most of all, because my wife is due in July with our first child. I want to be able to be active in my child's life, to be able to get down on the floor, play with my baby. The thought of having to be a spectator in my child's life is the motivation to take advantage of any opportunity that might improve my mobility." So what Chris wanted to do was be able to get on the floor, play with his child, and get up independently, not have to have his wife help him. This is Chris's team. Unfortunately, you can't see the words on the side, but what this is meant to illustrate, Chris and his wife Shonda are there in the middle, and then everyone around them is from a different place. We have somebody from VHA, somebody from VBA, we have folks from Balance Innovation, folks from Case Western Reserve, Cleveland State University. A really great cross-section came together to solve Chris's unique challenge. Oh man, all the words are gone. So anyway, what his team ended up developing was something really simple. Most of the time he ambulates with a cane, and what they did is they had buttons on the side of the cane that depressed into a tripod type of a device. And it had a disc that was positioned at just the right height, which allowed him to get up on his knee and then push himself to standing. So it was really simple, really easy. Most of the parts were fabricated using a 3D printer, and it was something he was able to walk away and use immediately after the event. So this was taken a couple months ago. That's Chris and his new daughter, Evie. He's still using the device. But the really cool part is what happened after that. So I said that this was a collaboration, a partnership. So VA Tech Transfer Assistance Project and the Human Engineering Research Laboratory Partnership in Pittsburgh took on this project. So for 2020, it received additional funding for future R&D. So hopefully we can take this solution, bring it to market to help a lot of people. So one really cool thing that I failed to mention at the beginning was that this is a global event. So we have veterans from the United States, we have veterans coming in from Israel, and we have teams of experts from across the country. Not just in Cleveland, which is the home of it, Cleveland's great, but we're seeking to expand it. A solution for one is a solution for many. And these are some of our partners. We can't do it alone. I think that's the value of the CAMVETS program is that, like I said from the beginning, it's really a shared partnership. Thank you.
Great work, Danielle. Our next presenter is Alyssa Welch from the Central Arkansas Veterans Healthcare System, who's going to talk about engagement solutions. Is Alyssa?
Have any of you ever been stuck in bed for a prolonged period of time? Maybe a week, a month, maybe even a year? And what about if your engagement during that whole time was stuff like this, like, Miss Welch, it's time for your medicine. Miss Welch, it's time for your dressing change. Or here's my favorite, Miss Welch, have you had a meal today? So this is the reality for many of our veterans in our community living center. And so because of their being bedbound, a lot of them experience loneliness, isolation, and they just miss out on what's going on around them. Oh, we won't go forward too far. Okay. So what if you could go to bingo? Or what if you could go to a concert that's on campus? What if you could participate and see the cars rolling in for our annual Dad's Old Car Show? You can. And I've made that possible. And here's the solution that I came up with. So after working for about 5 years in our community living center, I've started using multimedia to include veterans in activities that they would normally miss out on. So my channel, Rec TV Channel 74, it has information on upcoming events, scheduled activities. We have remote live broadcasts, curated programming that includes movie requests by veterans, vintage TV shows, maybe even music specials that they would appreciate seeing. And so what I found is a lot of our guys love Westerns. And so all day Saturday, Rec TV shows Westerns for those guys. And so we also have other programming that's very specific to our community living center. And so if you want to play bingo, you can play bingo. This is a picture of our company that helps provide our cloud content. That was our first live bingo. We were all excited about it. And so all you have to do is our veterans that are in their rooms, they are provided with a card. We have volunteers and staff that help them. And then our dementia unit plays right there in their dining room on their unit in a secure location. So if you happen to get a bingo while we're live broadcasting, you call our Razorback room. It's extension 73525. I know y'all need that number. And you can claim your prize. And just like being able to be live at our bingo, you can also be present at resident council meetings, chaplain services, concerts that our Volunteer Services brings in. So just about anything that's going on campus, you can be a part of from your bed, if you're bedbound, or maybe just because you've had a long day at dialysis or chemo treatment or some of the other things that go on with our community living center veterans. So if you can't be there in person, we're trying to bring that to you. I think it's a great idea, but you should hear what some of our veterans say about it. So if my slide please, go ahead. So Mike is one of our veterans who's been here several times. And so he loves bingo. It's one of his favorite things. And so one of his visits, he was bedbound with wounds, and he didn't get to come to any of the scheduled activities, recreation therapy, diversional, whatever. And so he hated that. And so then the next time that he came, he was like, oh my gosh, I get to play my favorite game right from my bed. So he really enjoyed and appreciated that. We also have Mr. Marchant's not pictured, but he was another one of my veterans who was who was bedbound because of wounds. And although he didn't talk to me very much, I went and asked him one day and said, "What can I do to make this better? You know, what would you like to see?" And so he was like, "Oh, more John Wayne." So, so we included more John Wayne. So as you can see, veterans, Mr. Aubin is on the bottom. He's been with us several times and he enjoys bingo, even though we don't give millions away. But so this is just a great opportunity where we've been working to engage our veterans who don't normally get to get out and do things. They, instead of just watching something, they get to participate. They can pick up the phone and ask a question to resident council or do some of those things. So we're hoping to continue this, and thank you for the support that we've gotten, and hopefully we're looking forward to a spread maybe in the future. So thanks.
Thanks, Alyssa. Next, we'll have Jeffrey Heckman from the VA Puget Sound Healthcare System, who's going to talk about Flow 3.
Yeah. All right, thank you. So I'm here to talk about Flow 3 today. So Flow 3 provides faster delivery of prosthetic limbs for veterans. Will be available in the marketplace in January, and I look forward to sharing that with everyone. So to date, Flow 3 has changed the lives of almost 3,400 unique veterans, providing over 3,800 complete prostheses or socket replacements to veterans in an expedited process that saves 16.1 days. So what does that mean? Across the country, if you're a veteran that goes to a Flow 3 site, your prosthesis prescription is being authorized 16.1 days sooner than across the country. So our national average right now is 23 days from a prescription to an authorization, and we've been able to get that to under a week. And these are the patients that we're seeing. So our patients are presenting to us and saying, I have a mountain to climb. So we perform that evaluation or assessment, we develop our plan, and then the process begins with that prescription. So there's a prescription. That prescription requires a specification by a VA prosthetist. The patient will choose whether they're going to a VA or a non-VA provider. That order will be specified based on the micro-purchase threshold to identify who is going to be performing that purchasing action. And then the limb is fabricated and delivered directly to the veteran. And then the final step is a verification, where the patient comes back into clinic for evaluation with the clinic team to ensure that high quality of care. Let me show you how that works. Yeah, no. There we go. Okay, so we can run the video. Can we run the video? Thanks, sir. So this is an example of how the process works. Patient comes in with their spouse, is evaluated by the amputation clinic team, and a prescription is able to be entered directly into the computer using CPRS templates. Our providers are able to then go in using a custom consult comment tool and directly add codes onto that prescription in order to specify exactly what we need to the care to be provided. Our purchasing agents are then able to go into an app and then identify from an automated list those codes that will be used for the purchase order authorization. Items are purchased and delivered directly to our staff, where they can perform that fabrication and then directly deliver the prosthesis as prescribed to the veteran. The evaluation can occur directly with the veteran to ensure that high quality of care, and then veterans and their providers are able to evaluate the outcomes directly in the app in order to demonstrate progress and see how our patients are doing based on the prosthetic limb care that we're providing. So here we are back in 2016. We were developing this process, developing this system in Seattle. So we were able to identify the patients that we were providing this care for. So this is a heat map of where our veterans live. So we're prescribing care out of Seattle to the Pacific Northwest. patients in Alaska, Washington, Oregon, and Idaho. As we'll see in 2017, we continued to expand. You see that more patients are receiving this care through this system. In 2017, we were able to work together with the Innovator ecosystem, and we're able to win the Shark Tank competition. That Shark Tank competition brought us to Visit 12, where we were able to train staff in Milwaukee and at the Heinz VA in Chicago, and we were able to make an impact in 2018 on Visit 12, as you can see, building up. Thank you. I'm gonna go quickly ahead because I got a minute left here. And in 2019, we were able to spread to 25 total facilities. Visit 22, all 7 of the regional amputation centers in the amputation system of care, which I heard is the ASOP. And so we've got a lot of great feedback. We're working directly with a team from Query in order to understand the impact of our training and our implementation strategies. So we've got a lot of great feedback. My favorite one is from a contracting officer saying, flow is awesome. It's awesome for me because we support 8 different sites for Visit 20, and each site submits a request differently. So how do we standardize and make that consistent? Now let's imagine we have a patient in their house working in their workshop, and they would be able to access directly their care through our new electronic medical record, as you heard from our folks in Cerner. So here I am getting alerted of this patient's need. I can access our new modern electronic medical record through my tablet, and then throw that prescription directly to our VA prosthetist, who can then access that order, specify it using specific codes, and be able to get that device delivered directly to our veterans so that they can continue to function and perform the activities that they enjoy, optimizing their quality of life. This is our future. Thank you.
After seeing the presentation in the other room, I don't think the future's that far off. So our next presenter is Regina Cunningham from the Lexington VA Medical Center. She's going to talk about the impact of modernization via digital dentistry.
Is things on? Yes, okay. First, I'd like to start off by saying how impressed I am with this entire experience and with the technology and the advances that are being made with digital innovation in the VA system. It is incredible. And to those of you who are out there, I cannot wait to use many of your innovations in dentistry. And we're not far behind in digital dentistry. We are, in 2019, we were awarded a seed grant, and I'm happy to share with you guys the results of that. We are truly applying the 3-box solution toward patient care quicker. Here we go. We're truly applying the 3-box solution to take what we have known, discarding a good portion of that, and using new technology to plan for the future and to integrate the digital technology that you guys are developing out there. And I can't wait to see where we go. But so far, we're baby stepping. And we have integrated thus far 1 digital scanner and 1 digital mill. And we're using that to measure the ramifications that it can have on our ability to provide improved clinical access for patients, to be able to improve their perception of their care in the VA, and to provide same-day dentistry so that we can eliminate cost or reallocate resources so that we're using our time and our money more effectively. If we can do that and save dental shots, who in here would like to do that? I'm just saying, anybody in here would like to have dental shots? Because if you do, we need to talk later. JK. So first, let's look at the workflow. This is a traditional workflow for conventional crown and bridge. We bring it in, we numb you up, get a shot, prep the tooth for a crown, and send it off to a lab. It can take up to 8 weeks later to bring a patient back in for us to put that crown in. For a second appointment, we have to numb you up, take the temporal, fit it, blah, 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 blah. Anybody in here enjoy that process? No. If you could have that done in one trip, who in here would be in favor of that? That's what we're talking about. Chairside, we're eliminating a lot of the fat. We're cutting the fat. So, and we're doing this by removing the process where we take an impression and send the case to the lab. Instead, we're doing a chairside scan with a digital scanner, and we're creating a crown for that patient. Chairside, within 20 minutes, the patient is going home. So I have yet to have a patient complain about having to not make another trip to come see us. So this is how we made it work. We received our funding last year, and by the time that we got through contracting, we were toward the end of the second quarter. In fact, our first data was collected on April 17th, 2019. We obtained 1 scanner and 1 mill for 8 doctors. And so to make things streamlined and for data tracking, we made use of our dental SharePoint calendar so that we could put the doctor's name, the tooth numbers, so we would be able to track the number of patients that we were able to treat. We were able to see whether we needed more than 1 appointment for these patients because we could drill down on the date and time, looking back into CPRS, the corresponding appointments. And we were able to do a cost analysis based on what our normal clinical chair time costs to operate per hour, as well as what our average cost for travel claims could be, as well as our cost elimination by lab bills, etc. So here's what we found. We found that we were able to eliminate in this small, partially integrated grant, we were able to eliminate 86 clinical hours, which results in a reallocation of $30,000. $30,000. If we were to, for 43 patients and 50 units of crown and bridge, $30,000 is nothing to sneeze at. Our travel claims reduced from 3.6 to 1.8 thousand, and patient satisfaction improved from 89% to 100%. So that's nothing to sneeze at. We estimate that were we to, because there was a period of time we were down due to technical error, my fault. So we really have 4 months of data. That's really 4 months. If we were to estimate our cost savings over the course of the year, we're looking at $104,000. And so, you know, we can scale this. We can scale it across 180 dental clinics in the country. So, thank you.
Testing, there it is. Okay, our next presenter is Grant Cannon from the VA Salt Lake City Healthcare System, who's going to talk about rheumatoid arthritis dashboard to improve quality of care. We get to test on it.
Great innovative. Okay. Any hints? Okay, good. My name is Grant Cannon. I'm a rheumatologist and innovation specialist from Salt Lake City, Utah, and I'm happy to be here today to talk to you about using a rheumatoid arthritis dashboard to improve quality of care. I'd like to start off by asking you a question. If you had hypertension, would you go to a doctor that didn't measure your blood pressure? Of course not, because we know that measuring blood pressure is important for both the diagnosis and monitoring the disease, but also for preventing the complications as we do treatment, as we can prevent things from happening. We're interested in doing the same thing to evaluate rheumatoid arthritis. It's a chronic disease affecting 75,000 veterans that has severe disability and joint damage. Our CPR systems cannot retrieve the information we need in real time to treat these patients. In order to evaluate these patients, we do joint counts, lab tests, global assessments, and the CPR system is basically data-rich but information poor. We need a system that allows this information to be available to the patient and their provider in real time. What we saw in a survey of 12 VA medical centers is when we were able to measure disease activity, but retrospectively, only 43% of the patients with active disease were actually receiving a timely intervention and therapy. This would be like 60% of people with blood pressure not getting treated at the time of their clinic visits. So how did we approach this? By developing a rheumatoid arthritis dashboard that has 4 major components. The first one is a measurement of patient's demographics. There's a calculator which can allow us to calculate disease activity. The second part is a measurement of the patient's demographic information. The next is an active measure of the patient's current and past medications, and then a plot of the patient's disease activity over time. Now, I know this is a little complicated, so let me show you how it actually works with a patient. Here's a patient that came in to see us, patient A. This patient came in and had severe rheumatoid arthritis. The first thing that we did was we put in his information to the calculator. I think we will put it in the calculator. Okay, here's patient A, and we have his data. We put into this calculator. When we do this calculation, we can calculate his disease activity, and it comes up here by hitting our calculator. It works faster at clinic, actually, which is his disease activity there in red is measured at 5.3. That's like having a hemoglobin A1C at 12 or having a blood pressure of 180 over 120. So what we did with this patient is we started him on his medications, plotted out his disease activity, and over time we started different drugs. And here we started our first drug with flutamide and other agents going forward. This is going backwards now. There we go.
Point it toward the computer back there.
So here,
There you go, sir.
any help? Can we just advance it?
I'll advance it for you.
I'll just say, go ahead. So I gave these different drugs, and you can see he was great next. It went on, and eventually found a drug, and you can see how his disease activity dropped off on that bottom line. The point is that we were able to measure this information in real time. And if we go on a little bit here, just keep going. Click, click. We calculated disease now. Oh, back one if you can. So what we have here is we got Mr. Back one if you can. Okay, got to the point here where it was in the green below disease activity. So the point here is not so much the technical part, but that we were able to actually in real time measure this patient's disease activity, have conversations with him as we went along, and saw that he improved. So this was a helpful thing. Let me give you another example, I hope, if we can move on to patient P. This patient's a patient who's had long-standing rheumatoid arthritis with us. I'll put that there. We can advance it. Patient P, he had 13 years of rheumatoid arthritis. We never seemed to be able to get it under control. Can you go ahead? His activity was also in the 5s. And what you can see here, next, is that he had gaps in his therapy. When we looked at it, he had all these times from 3 months between prescriptions. Next, he also were able to calculate that when he was given his drugs, he was only taking it 70 to 60% of the time. So essentially, we're able to demonstrate to him in real time how we know that he's not taking his pills. As opposed to trying to find new medicines that work for him, we need to find ways that we can make him actually take the medicines that he's prescribed. Next. So what have we learned from this? We've learned that we can actually improve the treatment of our patients with rheumatoid arthritis by measuring their disease activity. When we look at our pre-implementation, we had about a 43% rate of implementation of active therapies in patients with active disease. And then we went up to 81% after the implementation of our dashboard. What are the lessons we've learned? We've learned that it's possible to create a clinical dashboard that works and it can actually make a difference in real time. We can prove that this improves quality care, but more importantly, it represents a technology and system that we can actually use to apply for other chronic diseases. And I'm happy to say it'll also work with CERN. Okay, thank you very much.
We're gonna find the sweet spot before it's over. Okay, our next presenter is Renee Butler, who's from the Central Arkansas Veterans Healthcare System, and is going to talk about the shoe slide.
Usually I'm not the lucky one to find a sweet spot, but we're gonna give it a shot, yeah. My name's Renee Butler, and I'm an RN at the VA hospital, been with them for 11 years. I'm also a proud Navy brat. My dad's a retired Master Chief. So I have that connection that every patient can be possibly my father. We all know that we're honored to take care of our veterans because as servicemen and women, these veterans are the reason we have our freedom and independence. So what about the freedom and independence of our veterans? Too many of our veterans are losing their freedom and independence when they lose their mobility. We owe it to them to fight for their mobility, and I got to interview several of these patients. I want to talk to you about Miss Eleanor. Miss Eleanor suffered a stroke a year prior. She was just the sweetest little woman, but she's now confined to a wheelchair. Her daughter has become her caregiver. Now, throughout the interview, she hit on some things that I hadn't thought of before, but the one that resonated with me. She told me she's not incontinent because she just can't control her bladder. Sometimes she wets herself because her daughter just can't get to her in time. And then she shared that when she told me, she said, sometimes it's because I know my daughter's tired. I know that her back hurts. And I quote, I don't ask her to pick me up because she's picked me up so many times today, I don't want to be a burden. So she waits, and she doesn't ask to go to the bathroom, and she waits in a wet breeze until her daughter can change her again, put her to bed, and set her down for the night. She's not going to ask for an additional change. Working on the VA rehab unit, I work with hundreds of veterans like Miss Eleanor who lost her mobility to ischemic stroke. And they've either lost paralysis on one side of the body, so they're no longer able to pick up the leg in order to be able to walk, or once they're able to walk, they learn to throw that leg. And when you're throwing that leg, they're leaning, they're now frequent fallers. You know, they don't have the mobility still that they need to have. So transferring these patients from wheelchair to bed, in wheelchair, it's exhausting. It's hard, it's tiring, and it's dangerous. And like everybody else out there, I thought, gotta be a better way. Didn't find one, gotta make one. Literally walked the aisles at Home Depot, and I'm thinking contractions, and lift the leg, I'm thinking contact stuff. This is as low tech as you can get. I walked the aisles, and there it was in front of me. This is a friction problem. I do not have to correct an underlying medical problem to make the patient mobile. So, low tech, this is the supine, simply placed on the shoe. We have two devices. One is for transfer, one is for more permanent for the veteran to be able to go and walk. We reduce friction. This is about as fast as a demo, and this is as easy as it is to tell a patient.
This is for dancing.
That's it. We are sliding across the floor. They do not have to pick their foot up. They can pivot. They can turn. If they're not able to support their weight, I'm able to pivot them with me by pushing their feet with me. Like I said, all this high tech is awesome, and my solution is as low tech as you can get. Now, we've had great results. We are still, I'm still making them. Everybody else's garage. I'm still making mine. We're still prototyping. But results so far, feeling scores,